So this is the third part of the lecture. This lecture we are going to focus on the central acting antihypertensive and also diuretics. So the learning outcome um, is especially on the diuretics used in the treatment of hypertension, focusing on thiazides, the pharmacokinetic and pharmacodynamic of one of the thiazide, which is hydrochlorothiazide, and it's used in hypertension and side effects. So far, we have covered alpha and beta blockers, and now we are going to cover the centrally acting antihypertensive drugs and diuretics. And for the number 4, 5, and 6, uh, there will be a separate lecture for that. Let's go on to the centrally acting antihypertensive drugs. As the name suggests, centrally acting, that means these are the drug that acts on the central nervous system. So it's divided into the first and second generation. The first generation is drugs that acts on the alpha 2 agonists in the medulla of the brain. So the example of the drug is clonidine and alpha-methyl-dopa. So this is the picture of the tablets for the first generation centrally acting antihypertensive drugs, okay, clonidine and methyl-dopa. And the second generation centrally acting is drugs that act on the imidazoline receptor or I1 receptor and act as an agonist. So only drug uh, available is moxonidine. Mechanism of action of centrally acting. Um, the there's two type of receptor in the medulla, in the vasomotor center. There's alpha 2 receptor and also I1, which is the imidazoline receptor. So for the alpha 2 receptor, what the drug, the first generation clonidine and alpha-methyl-dopa, it will bind to alpha 2 adrenergic receptor, and when it binds to it and act as an agonist, and it will inhibit the release of noradrenaline or norepinephrine, and this would inhibit sympathetic outflow to the periphery. So this is the term called peripheral sympathoinhibition. Right? So what will happen to the central to the cardiovascular system in the periphery? So when there is a reduction in the peripheral sympathetic activity, uh, especially in the vessels, there will be a reduction in the sympathetic tone on the vessel. That means there will be vasodilatation of the vessels, and when the vessels vasodilate, the total peripheral resistance is reduced. Okay, so then this will cause reduction in the blood pressure. Okay, uh, at the same time, if you look in the diagram here, there's also increase in the parasympathetic activity outflow. Right, so this the parasympathetic activity through the vagus nerve, which supplies the heart, and this will actually lower the heart rate. Okay, so the combination of it will cause a decrease in blood pressure. Looking at one of the centrally acting first generation drug, the alpha metal is actually a structural analog of dopa, and it functions as a prodrug, uh, which will be converted to alpha metal dopamine. Okay, so the alpha metal dopa is converted to alpha metal dopamine, and this alpha metal dopamine acts as the force neurotransmitter. It's almost similar to norepinephrine or noradrenaline. Okay, so, except that it has a methyl group. So it will also bind to the alpha 2 receptor and acts as an agonist. And when it binds and acts as an agonist uh, in the medulla, the vasomotor center, it will decrease the sympathetic outflow. What are the adverse effects of centrally acting antihypertensive drugs? First one is edema, because it causes vasodilatation. There will be some fluid from vessels being leaking out that can cause fluid retention. Sedation, because it acts in the central nervous system, seems to have some sedative effects, and uh, it may also be used as part of the sedative hypnotic drugs to sedate the patient. And because it causes vasodilatation, it can cause orthostatic or postural hypotension. Means the patient, from lying down to sitting up position, uh, sudden movement may cause a drop in BP, and that may cause a blackout in patient. Bradycardia, because of the parasympathetic activation. There's sympathetic inhibition, but there's parasympathetic activation, and through the vagus nerve slow down the heart, and so that can lead to bradycardia. And dry mouth, which is uh, known side effect of the clonidine or metaldopa, right? So it has something to do with alpha adrenergic activity in it. Uh, okay, so centrally acting antihypertensive drug can be used as the management of hypertension. Okay, so especially if alpha metaldopa is the drug of choice for treatment of pregnancy-induced hypertension. So in some of the women who is pregnant, they develop hypertension. So since alpha metaldopa is safe, there's no adverse effect on the fetus. So it's being used to lower the blood pressure in these women who's pregnant and they develop blood pressure due to the pregnancy. Right. So the warning is clonidine. Once you are on clonidine for a long time, uh, you have to warn the patient they should not stop the drug suddenly, because what would happen is when they stop suddenly, their blood pressure will go up, and this is called rebound hypertension. Okay, so um, for clonidine, you should advise the patient not to stop the drug suddenly. Okay, to the next, the second generation centrally acting antihypertensive agent, the drug that act as an agonist on the imidazoline or I1 receptor in the vasomotor center, the medulla. The name is moxonidine. Um, so if you remember back, if you look back at the diagram just now, there's two receptor there, alpha 2. That's the drugs, the centrally acting, that is the first for the first generation, alpha beta-dopa and clonidine. But there's another receptor which is called imidazoline I1 receptor, and the drug moxonidine has much greater affinity for this receptor, binds to it rather than alpha 2 receptor, and the same uh, uh, mechanism of action. It will cause inhibition or decrease in sympathetic nerve activity in the periphery, and this leads to vasodilatation and so on, and it will cause a decrease in the blood pressure. Okay, so moxonidine is used for the treatment of mild to moderate hypertension. This is a picture of the moxonidine tablets here. All right. Okay, that's it for the centrally acting antihypertensive agent. You have three agents just now. First generation is clonidine, alpha-metal-dopa, and the second generation is moxonidine. And you have to remember the receptors. Increase of the affinity for the first generation is toward alpha 2, the allergic receptor, and the for the moxonidine is imidazoline receptor. Okay, so and then the mechanism of action. Next, we will now go on to the diuretics. Actually, there are many type of diuretics. You can find more details on the diuretics in the lecture on diuretics, lecture on diuretics, and the but for the antihypertensive agent, we're just going to concentrate on one of the diuretic, which can lower the blood pressure. Okay, so normally diuretics is used as the first line drug because it of its safe and effectiveness in preventing hypertensive complication. So the example that we have here is a diuretic called thiazide diuretics. So the name is hydrochlorothiazide, and another example is chlorothalidone. So this is a picture of the tablet of hydrochlorothiazide. So the mechanism of action of thiazide diuretics, um, initially, just like the other diuretics, what it does is it acts on the distal convoluted tubule of the kidney. So and it blocks the certain transporter, and that would therefore the sodium is not reabsorbed. Okay, the sodium is now excreted more rather than being reabsorbed into the circulation. And when sodium is not reabsorbed, it will be excreted along with the water. So what will happen? There will be salt and water being excreted out as in the form along the urine, and therefore the volume of the circulating blood is reduced. Okay, so what will happen is there will be a drop in the blood pressure. Okay. Um, uh, the secondary cause of that is because of the reduction in the cardiac output, right? And that also leads to reduction in blood pressure. That is initial um, action of thiazide diuretics. After the continuous therapy, another mechanism sets in. Um, there is a reduction in the interstitial fluid volume, and that will lead to the reduction in sodium concentration, the smooth muscle of the vessels, and also that will lead to reduction in the calcium concentration in the vessels, smooth muscle of the vessels. And when there's a reduction in calcium, calcium is important for contraction of smooth muscle, and therefore the reduction in the calcium, there will be reduction in response to the cell surface receptor to uh, any vasoconstrictor hormones, um, and therefore it will cause relaxation of the arterial smooth muscle. When the arterial smooth muscle relax, that means it will vasodilate, and when it vasodilate, it will have reduced the total peripheral resistance, and therefore it will cause a drop in the BP. And at this time, the cardiac output will be back to normal. Okay, right. So that's the mechanism of thiazides. Clinical use, thiazides is being used as monotherapy. It means a single drug, especially for those who needs to be started mild hypertension, and for it can also be combined with other medication for more severe cases. Um, uh, Thiazide is used at low doses because studies have shown that when used at high doses, there's not increase in the effectiveness in lowering the BP. So uh, what you get if you use the high doses is just you'll get the adverse effect of thiazides, uh, such as the potassium loss. So the recommendation is to use low doses, and this is called ceiling effects. Low doses, um, and at the same time you get less side effects. It can combine with other antihypertensive agents, for example alpha and beta blockers, cosympatholitics, and ACE inhibitors and calcium channel blockers. And this ACE inhibitor and calcium channel blockers, uh, we will deal that with the separate lecture. Side effect of thiazide, as we have already mentioned just now, is potassium loss. And how do you avoid the potassium loss due to intake of thiazide? By using low doses. We have mentioned this, and diet. You have to take a diet which is rich in potassium, and you can combine it with another diuretics called potassium sparing diuretics, triamtrin. And so thiazide cause potassium loss, but this potassium sparing diuretics spares potassium. I mean, there does not cause potassium loss, so combination of it would be ideal. Another thing that thiazide cause is especially for this is especially for those with gout, this increase in uric acid level. So thiazide also has been shown to increase the uric acid level. It can cause hyperuricemia, can lead to gout, and it also causes dyslipidemia. This is increase in the bad cholesterol LDL and VLDL, which can later cause atherosclerosis. And also it can cause hyperglycemia, which is glucose intolerance. It can cause hyperglycemia, and this can worsen the condition of diabetes. Alright, that's it for the thiazide diuretic. We've covered just now um, uh, three lectures. The first lecture is introductory. Second lecture, we have covered alpha and beta blockers, and we've also covered centrally acting antihypertensive and diuretics. Maybe to some of you, you can use this, remember A, B, C, and D for the antihypertensive agent. A is for alpha blockers, ACE inhibitors, ARB. We have already covered alpha blockers. Later we will cover ACE inhibitor and angiotensin receptor blockers. We've already covered B, we've already covered beta blockers. And C, we've already covered centrally acting antihypertensive. Later on we will cover the calcium channel blocker. And D for diuretics, we've already covered diuretics focusing on chlorothiazide. That's it. Thank you. Okay, back to the learning outcome. So next few slides, I will cover the alpha blockers and the beta blockers. So let's first start with the alpha blockers. So we already know what is alpha 1 and alpha 2 receptor. So what are the drugs that can interact or can block this receptor? First is the competitive blockers. The short-term one is the competitive blocker of alpha 1 and alpha 2 is the non-selective blocker called phentolamine, and alpha 1 selective blocker, which is called prazosins. Okay, so this is the important one, prazosin. And longer acting alpha 1 selective blocker is doxazosin. Whereas for non-competitive, um, we have alpha 1 and alpha 2 non-selective blocker. It's called phenoxybenzamine. Okay, so this is a long-acting one, can be 12 to 18 hours the duration of action, and this is bind strongly to alpha 1 and alpha 2 covalently. Okay, so that is why not much use because of this very strong action. So for alpha blockers, the mechanism of action, if we can concentrate on the blood vessels, because there's alpha 1 receptor in the blood vessels. So if you block the alpha 1 receptors in the blood vessel, you would reduce the smooth muscle contraction. That means you would cause the blood to vasodilate. That means you would drop the peripheral resistance. That means the blood now has less resistance. It can flow much more easier, and therefore this will drop the BP. Okay. In other words, the noradrenaline is there. Now, if you noradrenaline will bind to alpha 1 and cause vasoconstriction when there's activation of the sympathetic nervous system. But if you give alpha blockers, alpha 1 blockers especially, it will block the, it will bind to the alpha 1 receptor and blocks it. So it does not allow the noradrenaline to bind to the receptor. So that it will cause vasodilatation and a drop in BP. Okay, so that's the relationship between alpha blockers and vessels in terms of the vasodilatation and the drop in BP. So to have a look at more in more details, the mechanism of alpha receptor blockers. So you have just now selective alpha 1. It will bind to alpha 1 receptor in the vessels, and this we've already discussed this. This will reduce the peripheral resistance of both type of vessel, whether it's arterial or venous, and therefore it will cause a drop in BP. This is the action. If someone have high BP, this is how alpha blockers, especially alpha 1, will decrease the BP by its action on the smooth muscle of the vessels. Another way is there's also alpha 1. We've already discussed this in the kidney. If you block this alpha 1 in the kidney, you reduce the sodium and water reabsorption. That will reduce the blood volume, and also that will lead to reduction in blood pressure. If you use the non-selective alpha blockers, that means it will block both alpha 1, so you get all these effects, same effect on the vessels, same effect on the kidney. But there's another action, extra action, because it's alpha 2. It also blocks alpha 2. So if it blocks pre-synaptic alpha 2, we've covered this alpha 2, and it would promote the release of noradrenaline. Okay, because alpha 2, if you activate it, it will inhibit the release of noradrenaline. It will inhibit the sympathetic nervous system. But if you block it, then you would promote the release of noradrenaline, or you promote sympathetic activity, and then in the heart can lead to tachycardia. Okay, so that is the difference if you want to use selective alpha 1 blockers and non-selective blockers, alpha 1 and alpha 2 blockers. Okay, so that's important. Okay, let's look closely at this selective and non-selective. So we already mentioned just now, selective alpha 1, non-selective alpha 1 and alpha 2 blockers. Example is phenoxybenzamine, which is a longer acting one, and phentolamine, it's a shorter acting one. Okay, they are not used in chronic hypertension. Okay, so because of this alpha 2 effects, it can also cause tachycardia. So it's used mainly in the disease called pheochromocytoma, which is the excessive release of adrenaline by the adrenal medulla. Okay. Okay. Whereas for the specific alpha 1 blocker, which we have covered just now, prazosin, the short acting, and doxazosin, the long acting, they are used in essential hypertension, chronic essential hypertension, because they've been shown just now. We've covered the mechanism to lower the total peripheral resistance and reduce the BP, and it will not cause tachycardia. There's no reflex tachycardia because it does not block alpha 2, just like these non-selective, and also it also block alpha 1 central adrenal receptors and blunt the reflex tachycardia. When there's a drop in BP, the baroreceptor detect this and send a signal to the brain and to increase back, to try and increase back the BP, and this is by tachycardia. This is called reflex tachycardia, but that will not happen because the alpha 1 blocker blocks the central alpha 1 receptor as well. So this is a picture of the prazosin. Okay, clinical use. Of course, we've already covered this. This is used in hypertension. It can be combined with diuretics. The action is different. The alpha blockers would vasodilate to reduce the total peripheral resistance, whereas diuretic is to reduce the volume by reducing the sodium and water retention. Okay, or it also can be combined with a beta blocker. We'll cover this later. Beta blockers like propranolol, because if you give propranolol or beta blocker, it's good. It does reduce the blood pressure, but it also can cause unfavorable lipid profile. Can cause an increase in HDL. The LDL, the lipids lah. So you can combine it, and then you can reduce the beta blocker dose, so that to reduce the side effect of the blocker on the lipid metabolism. In other clinical use, this is good to know. You have is also used in patients with BPH, benign prostatic hyperplasia, which is difficulty in urination because of the enlargement of the prostate, and also is used in pheochromocytoma. Just now we've covered this. Pheochromocytoma, where there's increase in release of adrenaline and noradrenaline, and this can also lead to hypertensive episodes. Adverse effect of alpha blockers is due to its extension of its alpha blocking effects, which is called type A adverse reaction. The main thing that you have to remember is if you give alpha blockers to patient is orthostatic hypertension. There's a phenomenon called phenomenon of first dose. When you give alpha blockers to patient, you have to remind them to when they are sitting up from lying position, you have to do it slowly, because that can cause orthostatic hypertension, and then they can develop blackouts. Okay, so you have and therefore most of the time if possible, the drugs are given at night when you're sleeping, you're not moving around, and which can lead to orthostatic hypotension. And that it can also lead to reflex tachycardia, which is more for the non-selective alpha blockers, drowsiness, weakness, and urinary continence because you're relaxing the sphincter muscle, and also nasal congestion. Okay, so that's it for alpha blockers. Let's go on to beta blockers. Beta blockers can be divided in several ways. As this is one of the ways is to divide it into cardio non-selective. When you say cardio, that means beta 1. Beta 1 is the beta receptor in the heart. So if it is non-selective, you are also having this blocker. Beta blocker is also acting on beta 2. It's also blocking on beta 2. Example is propranolol. It blocks both beta 1 and beta 2, so it's non-selective. It's cardio non-selective. And we have pindolol. Other than it's cardio non-selective, it also have ISA, intrinsic sympathomimetic activity. It's like partial agonist activity. Okay. In terms of the cardio-selective beta blockers, we have beta 1, metoprolol, and then beta 1 blockers, cardioselective blockers with ISA, which is acebutol. And there's a hybrid beta blockers, and not only does it blocks beta 1 and beta 2, but it's also block alpha 1. This is good because, as you know, we have alpha 1 blocker like prazosin. When it blocks the alpha 1, it will cause vasodilation. So labetalol also blocks beta 1, which is also good because it will reduce the heart rate and heart contraction and cardiac output. That would drop the blood pressure. Only problem is, of course, it blocks beta 2 as well, and this can cause in the bronchus, smooth muscle, can cause bronchoconstriction. Okay, the mechanism how beta blockers can reduce the blood pressure. So beta blockers, the effect is again on the heart and on the kidney. Okay, so on the heart it blocks the beta 1. Okay, and beta 1, if you block it, you would have bradycardia or reduce the heart rate. You will reduce the force of the contraction, and then you reduce the cardiac output. I mean, the force of the blood on the vessels is reduced, so you get decrease in BP. Another way is beta 1. There's also beta 1 in the JG cells of the kidney. So these alpha blockers, the beta blockers can block beta 1 in the JG cells, and this will reduce the renin release, and the reduced renin release will reduce the AT2, angiotensin 2, and AT2 is the one that is responsible for vasoconstriction, and therefore if you block the renin release, you block the AT2, you reduce the peripheral resistance of the vessels, vasoconstriction of the vessels, and therefore you reduce the BP. Again, the AT2 is also responsible for the secretion of aldosterone. Okay, aldosterone is the responsible for holding the water and the sodium and water, the salt and water. I mean, it reabsorbs sodium, and when sodium is reabsorbed, the water will follow. So if you block the aldosterone secretion, the sodium and the salt and water is not retained, so it will be let out and increase in urine output. Therefore, this would reduce the volume of the blood secretion because you loss, especially loss of water. So when there's a reduce in volume of the blood, it will reduce the BP. Okay, so this is the mechanism how beta blockers can um, reduce the BP. So more complicated for the kidney part. So you have to know the pathophysiology. Hormonal renin, angiotensin 2, aldosterone, and this angiotensin 2 uh, can also have effect on the blood vessels. Okay. Right. Okay, let's get into more details on the drugs classified as beta blockers. Okay, propranolol, you know, is the prototype of beta blockers. It is non-selective, that means it binds to beta 1 and beta 2 and block these receptors. So the mechanism is when it blocks beta 1 and beta 2, it blocks the sympathetic tone, um, uh, and if the sympathetic tone is high, the effects are much greater. So in the heart, you reduce the heart rate, reduce the cardiac output, reduce the pacemaker activity as well. Okay, so if you look at the heart, you have that means it have negative chronotopic, reduction in heart rate. It has reduced in inotropic, which is this force of the contraction of the heart, and it also has some negative dromotropic. That means it reduces the conduction of the electric conduction in the heart. So therefore it will reduce the um, cardiac output, and therefore it will reduce the BP. In terms of the blood vessels, its probably action is probably via the reduction in the renin release. If you remember the diagram just now, if you reduce the renin um, released by the JG cells, you also reduce the AT2. AT2 is the one that binds to this receptor in the smooth muscle of the vessels, and it can cause vasoconstriction. So if you block the beta 1 receptor in the JG cells, reduce the renin release and you reduce the AT2 release. And if you have reduction in AT2, reduce the effect of the AT2 on the vessels, which is that means you reduce vasodilate vessels and reduce the peripheral resistance. Okay. A bit of pharmacokinetic. Propranolol is lipid soluble. It's however, it's well absorbed. It's given orally, and because it's lipid soluble, it can cross the blood-brain barrier, and this can lead to, drowsiness, can lead to nightmares, and it has quite a high first-pass metabolism. That means if you take it orally, 2/3 of it will be inactivated by the liver as it passes through the liver. Okay, and then it also has large inter-individual variation. This is the example of the drug. The commercial name is Inderal. Okay, and the clinical use of propranolol used in hypertension. We've covered that, and the various mechanism that propranolol as a beta blocker can do to reduce the high BP. And it's also used in angina pectoris, which is coronary artery disease, okay, because it also reduces the cardiac work and the oxygen consumption by the heart. And it's also used in MI and post-MI prophylaxis to protect against arrhythmia and limit the infarct size. It is also used in chronic congestive heart failure, okay, um, migraine and thyrotoxicosis. Adverse effects. Propranolol can cause, or any other beta blockers can cause dizziness, fatigue, and depression because it reduces the sympathetic nervous system, so you can easily get tired, dizzy, and suppressed, and is also has produced bad lipid profile, increase the VLDL, then the bad cholesterol and HDL. And in diabetics, you try to avoid beta blockers in diabetics, but if you have to give them, you have to make sure that they do not go into hypoglycemia, because diabetic patient can, if they skip a meal, or they can develop into hypoglycemia, and normally they will have symptoms. They are restless, they have tachycardia, they have sweating. But if they are on beta blockers, they will not have all these signs. Okay, so you don't know that the patient is actually in hypoglycemic state. Okay, so you have to be careful. And it is also not given to a patient who is having asthma and COPD, because propranolol is non-selective. I mean, it can also block the beta 2, and beta 2, which is present in the smooth muscle of the bronchus. If you block it, it will cause bronchoconstriction, because beta 2, it relaxes the smooth muscle in the bronchus. But if you give propranolol, it blocks the beta 2, you get bronchoconstriction, and that will worsen the asthma and the COPD. And normally for chronic use, we've been using beta blocker for some time. That means the beta receptors is synthesized more on the surface of the nerve. So when you suddenly block when you suddenly stop the beta blockers, there's a lot of beta receptor available, and the noradrenaline will bind to them, and this can lead to rebound hypertension. Okay, and if the patient is may have another angina attack because of the tachycardia and the uh, strong contraction to the heart, and that it can lead to another angina attack and possibly myocardial infarction. So if the patient is on long-term beta blocker, especially propranolol, you have to reduce the dose slowly, and do not, I mean, you don't suddenly withdraw the drug. Okay, that can lead to sudden withdrawal syndrome, because of the upregulation, it leads to increase in the beta receptors, and that means the patient is more sensitive now. Contraindication, that means you don't give patient who is on heart failure. I mean, the heart failure is, that means the heart is not at its best function to supply or to produce the cardiac output to supply the demand of the body. Okay, and so if you give beta blocker, you further reduce the function of the heart, and then you actually further aggravate the heart failure, or even a patient with a heart block, because beta blockers, propranolol, they would further reduce the electrical conduction in the heart, and then it would further cause the heart block. And also in case of cardiogenic shock, where the heart is not pumping enough blood toward the body and causing cardiogenic shock. Okay, drug interaction, you have to be careful when you give propranolol with other hypertensive medication. Drugs that reduce the blood pressure, like quinidine and beta-blocker, can cause a sudden drop in BP, and drugs that can also depress the heart, for example, calcium channel blocker, lidocaine, they can worsen the depressive effect on the heart, because beta blocker also depress the heart, and that can lead to heart failure. And just now we covered this, insulin and oral hypoglycemic drugs. Those diabetics, they are on insulin hypoglycemic drugs. They can have hypoglycemia, and then the propranolol, if given together, can mask the signs of hypoglycemia. Okay. Okay, next is another drug. The next is the another type of beta blockers, but this time is a hybrid um, alpha and beta blockers. The drug name is labetalol. It is a non-selective beta blocker. That means it blocks both beta 1 and beta 2. But at the same time, it's selective alpha blocker. It only blocks alpha 1 block. Okay, so that means it competitively block beta 1 receptor in the heart, myocardium. You know what that leads to? It leads to, the negative chronotropic, negative iotropic, negative chromotropic, reduction in cardiac output. And also at the same time, it blocks the alpha 1 in the vessels, the smooth muscle of the vessels, and relax it, so there's vasodilation. So these effects will cause a decrease in the blood pressure and reduction in the vascular resistance, and there's not much effect on the heart rate and resting heart rate and cardiac output or stroke volume, okay, because of the combined alpha and beta activity, and does not cause reflex tachycardia because of the combination of alpha and beta activity, blocking activity. And it is a safe drug. It's used in pregnancy-induced hypertension. You can have a pregnant woman, they develop hypertension during pregnancy, and because labetalol is safe, it's being used to reduce the blood pressure and with not less effect or less adverse effect on the fetus. Okay? So that's why it's being used in the treatment of PIH, pregnancy-induced hypertension. It is also available in IV form, so it's also used in hypertensive emergencies when the blood pressure goes very, very high. So you need to reduce the blood pressure fast to certain percentage, okay. So you cannot reduce the BP suddenly. You have to do it in stages, but you can do that using IV labetalol. You can control, you can titrate it, okay, to lower the BP to certain level, and then maybe to lower them later slowly to the normal levels. And it's also used in pheochromocytoma, which is, we already know, this is the tumor in the adrenal medulla, which cause an increase in noradrenaline, and that can lead to hypertensive crisis as well. Contraindication for labetalol is the same as what we've covered just now for propranolol. So it's the same. Okay, next we are going to look at the cardioselective blockers. Cardioselective meaning it blocks the beta 1 in the heart. And there's two types, there's metoprolol and atoprolol. Atenolol. Metoprolol and is more lipid soluble. Atenolol is more water soluble. And so when they act only on beta 1 in the heart, it has less effect, or because it's more selective towards beta 1, so it has less effect on beta 2, which is found in the smooth muscle of the bronchus. So this cardioselective blockers is safe to be used in patients with asthma or COPD. Okay. However, a recent study have shown that it is not totally selective to beta 1, so you have to be careful as well if the patient has asthma, especially if you're using high doses of metoprolol and atenolol. All right. And there's another beta 1 selective or cardioselective blockers. It's called esmolol. This is present in the IV form and with the rapid onset and short duration of action. So therefore, it can be given in the form of IV infusion during perioperative tachycardia. I mean, during operation, if you have tachycardia and hypertension, you can use esmolol and titrate it to reduce the tachycardia and hypertension. The last drug that we are going to cover here is the unique drug, unique beta blockers with partial agonist activity, or what we call a beta blocker with ISA. Okay, example is pindolol here. ISA meaning when it binds to the beta receptor, it will exert actually a low level of agonist activity. Um, while at the same time it acts as a blocker, as an antagonist. That means it will not, if given, it will not cause or cause little effect on the heart rate, resting heart rate. But when the patient is exercising, when there's increase in the heart rate, then it will block. Okay, so useful in patient who is naturally bradycardic at rest, and also beta blocker with ISA like pindolol may be used in clinical situation where non-ISA blockers are contraindicated. Okay, example in sinus bradycardia, sick sinus syndrome, Reynolds like syndrome, and COPD. And also the advantage of pindolol, it has a better lipid profile compared to the other beta blockers. Right, that's it for the beta blockers.